What if insight into your genes could lead to reducing the risk of, or minimizing the impact of, or even in some cases, helping prevent serious cardiac and neurological diseases? Today on WellWaveNOW, Dr. Marschall Runge reveals how genomics and AI are transforming medicine, helping doctors and patients take control of their future health. Welcome to WellWaveNOW, your portal for actionable wellness insights. We, Breck Rice, Dr. Bob Levine, and I, Tim Daniels, are your wellness catalysts committed to elevating your health, enhancing your functionality, and optimizing your performance at every life stage. WellWaveNOW, where timeless wisdom lights your wellness path. Today, we are joined by Dr. Marschall Runge. Dr. Marschall is an author, distinguished cardiology physician, researcher, and healthcare leader, and author. And he's at the forefront of genomic medicine with expertise in next-generation sequencing, also known as NGS, AI-driven diagnostics, and precision medicine. He has played a key role in advancing personalized healthcare approaches. These tools are being used across a growing spectrum of conditions, but today we'll discuss how genomics is changing the landscape of cardiology and neurology.
Hey, welcome to the show, Dr. Marschall. It's so great to have you here with us today. And you're a cardiologist by training, and so we do want to touch a little bit on the genetics of certain people that have inherited certain things that may turn into to heart issues, and so how much of that really plays into your genes and what you start with, right? The cards that you were dealt.
Well, it's great to be on the show. So thank you for inviting me today.
Yeah. So let's jump into some of the differences of, like I said, the cards that you've been dealt versus what we have control over, right? So, in when you look at the estimated range of people that are affected by what they inherit, in heart and neurological diseases, what percentage of the population just already has a hand that's been dealt to them that they need to be concerned?
Well, it's a significant part of the population. When I think about it, I divide them into two groups. One group is the group that is particularly driven by a certain gene defect. So those are the monogenic diseases. And then there are others who there are many contributors to their illnesses. And to take two examples of polygenic diseases, people with atherosclerosis, they may have many factors that contribute to their developing atherosclerosis and blockage in the arteries in their heart, not any one single gene. Similarly, take Alzheimer's disease. Again, another disease that there are many genetic factors that can influence it, but in both cases, environmental factors as well. But there's another set of genes and another set of diseases that really have a specific genetic component that has been described, that we know about, and in some cases can be treated, in other cases can't be treated. And this is probably accounts for 5% of the population. So it's very significant. It's not as common as heart attack and stroke are the most common causes of death in the United States and disability. But these are still quite significant. So there might be, the estimates range from 5 to 6 up to 20,000 people have a cardiovascular genetic defect. And they fall in different categories. The most common is what's called familial hypercholesterolemia. So these are people who inherit very high cholesterol levels, particularly LDL cholesterol. Not like most of us who might get away with taking a statin or dietary and lifestyle changes. These folks have cholesterol levels in the 500 plus. Another is an illness called hypertrophic cardiomyopathy. That's probably the second most common. Multiple genes impact hypertrophic cardiomyopathy, but it's a condition where the muscle of the heart gets too thick and it predisposes people to having fatal cardiac arrhythmias, fatal heart rhythms. And there's several of these that do have to do with fatal heart rhythms, or the risk of that. Another is what's called long QT syndrome. That describes part of the electrocardiogram. And it's something that used to be commonly missed. Now it's not missed very much anymore. But frequently young people can have sudden cardiac death because of that. There's a similar syndrome called Brugada heart disease, which also leads to fatal arrhythmias. And the final one that I put in this category is called Marfan's. So I don't know if you guys have talked about Marfan's before, but it's a defect in a gene that affects how the artery wall functions. And so these typically are people that can be tall. They have a certain look, the Abe Lincoln look to them, and they're at risk of having different kinds of cardiac problems, particularly an aneurysm that of the aorta leaving the heart. And so this one I always was kind of interested in because for years it was not realized that a subset of very tall people who were good basketball players had Marfan's. Another subset had hypertrophic cardiomyopathy. And so some of those sudden cardiac deaths could have potentially been prevented.
Okay.
Now, if you take a look at those, you mentioned that you mentioned 5% in the Marfans. So I was asking, you kept me from looking sharp, Dr. Marsh, because I was going to mention that it was they thought Abe Lincoln had that, but you went ahead and
sorry.
Everybody. That's all right. Now, so then you mentioned and you talked about Alzheimer's a little bit, I think, over on the neurological side. But I've heard there are some estimates out there that between 5 and 8 million Americans have the hereditary heart conditions of various types, and
yes,
8 to 8.2 million have genetic neurological disorders, and then there are hundreds of thousands who are kind of diagnosed on a yearly basis. But then you also mentioned that I think it was with the long QT used to be underdiagnosed. Do you think the rest of them are they being captured, or you think that those sometimes go underdiagnosed as well?
I think we have an opportunity. I do think they're all underdiagnosed, and we have an opportunity to improve that diagnosis. And as I sort of alluded to with heart disease, even with the ones that are purely genetic, there are things that a person can do, lifestyle, medications, that will lessen their risk of having sudden cardiac death. And sometimes surgery is part of that. And similarly with some of the neurological diseases. Now, there are neurological diseases, I didn't kind of go through a list of those, that are highly genetic. Sort of the poster child, if you will, is Huntington's disease. And Huntington's disease is a really tough one because, and we may talk about this later, but it's one that has such a strong genetic component to it that if you have, and it's very familial, if you have the gene defect for Huntington's disease, you're almost certainly going to get it. And again, the kind of example was Woody Guthrie. So Woody Guthrie, a famous, was it Arlo Guthrie? One of them, one of the Guthries had Huntington's disease. It's very disabling. His son did not. And when I say the gene defect, usually these can be any of a number of defects, but in a single gene. Okay. So it might be one place in a single gene.
But Dr. Marschall, you used the word familial, and I think it'd be worthwhile explaining that. Does that just mean runs in the family?
Yes, that's what I'm referring to.
Okay, great.
Well,
I just want our audience to know.
Yeah, tell us more about what some of those effects are that change the quality of life and how the family plans around that, right? So give us more detail of what these effects really are, on the family.
Yes, and they're important. So of the familial cardiac diseases that I described, they are uniformly have some form of therapy that can, and so it's a matter of not missing the diagnosis. And they can be familial, but they are familial, but they're different than the neurological illnesses. So the neurological illnesses, I mentioned Huntington's disease, and it's a progressive disease that may start with people having difficulty with movement or their thinking. There are others, for example, Parkinson's disease. Parkinson's disease does have several different causes, but the genetic form of Parkinson's disease is pretty common, and it's expected that itself will continue to increase, in part because we have some ways of treating Parkinson's disease, but it doesn't completely make it go away. With Huntington's disease, there is no therapy. Another common one is called, I should have looked up why it's called this, but it's Charcot-Marie-Tooth disease. Maybe you guys know why that's called Charcot-Marie-Tooth, but it is probably the most prevalent of the inherited neurological disorders. It's estimated that it's 1 out of 2,500 people, so that's pretty common. And in this illness, people lose their muscle mass, they lose their sensation of touch, and it can be very debilitating. So with these neurological diseases, they're limited therapies, and for most of them, and they're very disabling. And so I don't remember, I think we might talk about ethics around this, but it's less of an issue today. But it used to be, when genetic testing first came about, if somebody had a family history of Huntington's disease, it was a conversation with the family and with the person with Huntington's who might have inherited. Do you want to know?
Yeah.
And many people said, no, I don't want to know. It's going to ruin my life if I know in 25 years I'm going to be totally debilitated. All I need, but then the idea came forward. Well, do you want to have a family? And so that, I think, has gotten people more interested in genetic testing as genetic testing has become more available and more accurate.
Right. And then I used to run a home care. We never talked about this before. I used to run a home care agency for the elderly, operating in 3 states. So never had anybody with Huntington's or the Marschall tooth disease, but did have people with the ALS and Parkinson's.
Yeah.
And yeah, you could just, some of the things you see happen now. It's very devastating to the individual in terms of their lack of mobility, their, in some cases, the rigidness, Parkinson's even hallucinating, the ALS not being able to, to move, and the impact on the families, seeing people, seeing their loved ones in that condition, the amount of care they had to, provide either themselves or institutionalize them, or in my case, the amount of pay they had to have sometimes for 24-hour care on them. Very, very devastating, impactful change.
Yeah, you mentioned ALS. I'm bringing out all my analogies. So the so-called Lou Gehrig's disease. So Lou Gehrig, of course, was a famous baseball player who became quite debilitated. He's passed away. I had a good friend and a friend from residency who also went into cardiology, and he developed ALS. And the reason I'm mentioning that is for 2 reasons. One is he was misdiagnosed for a while, and he was a doctor, very smart guy, and he was having trouble with his legs, and he even went so far as to be diagnosed as, you have a lower back problem, you should have back surgery, which he did, which didn't help. And but the guy was absolutely an amazing person, and he did require a lot of help, a lot of care, had a very dedicated family. But I remember talking to him about a year ago, and he really couldn't move much of anything except for his eyes. Mm-hmm. But he was able to communicate by email. He could talk, but he was able to communicate by email and answer notes somehow by blinking his eyes. He had a program that would enable him to, without his hands, to communicate. So, as an example, I mean, people are getting more and more using technology to alleviate some of what they can't do. But for a disease like that, where it's not going to get better, it's a tough thing for people to keep their spirits up, for their family to keep their spirits up. Right. Really tough.
And I think to the point on ethically and being able to testing for it, that's another reason to do it, is to be able to prepare oneself, prepare one's one's family, and do it to really be able to adjust to and take on that role, so it just doesn't blindside them.
Right.
And we talk about that, right? That some people would rather not know, but let's take it to the other side of the coin, right? For things that are preventable, those we should be testing for and we should know, right? So let's jump into that a little bit. How many people suffer, cardiac events that you could have tested for ahead of time, or even neurological disorders that could have been changed ahead of time?
A lot, I think. Yeah. And for cardiovascular diseases, sometimes you have a hint that a person may have, for example, the enlarged heart, hypertrophic cardiomyopathy. Sometimes they pass out. And so if somebody has passed out, you need to really look into all potential causes. It could be that. It could be that they have a long QT syndrome or Brugada syndrome. And I'll tell you what is so amazing to me is when the Human Genome Project started in the 90s, I don't remember exactly how long it took. If you guys know the numbers on this, please tell your audience. But I think it took maybe 5 years and cost something like $2 billion. Now we can get a very reliable whole genome sequence. That means every every nucleotide in the human genome, which is like 4 million nucleotides. So it includes areas that code for proteins and other areas that we don't even know what they are. That can be done here at Michigan Medicine, where I am. This isn't unique. We're contracting with somebody to do it. It can be done for less than $400 and can be done in a few hours. Where, used to be, it would be, when this technology first became available, it was maybe $10,000 and took weeks and weeks to get the results. Part of it's the technology and sequencing. Part of it is the incredible power of artificial intelligence to be able to organize and analyze these millions of nucleotides in a person's genome.
Yeah, we're gonna talk about that for sure. But do you think that's maybe one of the barriers to people wanting to do early detection, is they think it's too expensive?
Yeah, I think that is a definite barrier, and I was surprised when my colleagues in lab medicine told me, "Oh no, we're going to be able soon. We're going to be able to do this for, I think it's $385 or something." I mean, that's less than it costs to get like a routine blood test for sodium, potassium, et cetera. So that is an incredible thing when you think about it.
So that full just so sorry, Dr. Marschall, but
no, go ahead.
Because that's kind of phenomenal. I want to make sure the audience and I understood it. So that testing that you just talked about that can be done in hours and covered all that will capture those hereditary diseases that we've talked to, and it does all that.
Yes, it does, and it can be directed. It's not the sequence in itself. The interpretation of it, which is now AI driven, can be detected. Look for long QT syndrome. This is my level of expertise with computers. So, I don't think you can literally tell the computer, look for hypertrophic cardiomyopathy, but it can be instructed to look for these abnormalities. Another kind of interesting thing about this, another ethical issue, just to ask you, have any of you signed up for 23andMe or Ancestry.com? Yeah, I got a free thing for Ancestry.com, so I signed up for it. There is a challenge with that, which is if you're just trying to see, are you related? You have relatives who came from somewhere else to the United States or president of the United States, and it's pretty amazing technology. But when you get your entire genome sequence, then somebody has to decide, wow, I wasn't looking for it, but on my data, the person's data shows that they have a high risk mutation. And it may be for other things, maybe for cancer, like the BRCA mutations. So what reaches the level that you really owe the person ethically to tell them, hey, you have this? I mean, some people will sign a release saying, I don't want to know what I have, which is interesting. I think, let me just say, I haven't had whole genome sequencing done. I'm not sure I want to know what I have.
Yeah, neither have I. I think the ancestry side, but I didn't go to 23andMe because I didn't want that other portion taken and didn't want necessarily out there. I think Dr.
Is there a percentage of false positives that come out of this at all, ever?
There is, and I think it's pretty small. I think it's very small, but I actually don't know that number. I should have looked, but that's a great question.
So I just want to mention to our audience that false positives means that you don't have it, but you're tested falsely to say that you have it. So that would be a false positive.
Right.
The other thing I'm interested in asking you, very fascinating work that we're talking about. How does epigenetics fare in this whole thing? I mean, are there any of these conditions that are kind of reversible if somebody's in the right environment?
Hold on a second, Dr. Marschall.
Yeah.
Bob, I'm going to do what you did to me last week when I mentioned epigenetics. And what does that mean, Dr. Bob, for those who don't understand?
I think we should have the expert, Dr. Marschall, explain that.
I'm all ears.
So epigenetics just means that the genome, the genes in the body can be modified to express differently by the environment. Which is very interesting. Yeah.
That's probably a better answer than I would have given, would have been, kind of too much jargon. But when you think of these genetic diseases, I literally think if you were forced into taking high school biology, you have ATCG, you have those nucleotides, and I think, well, instead of being AAT, it's AAA, and that difference in sequence can make a gene not work. epigenetics doesn't involve your DNA sequence per se, as Dr. Bob just said. It involves environmental interactions that can result in an important gene being either masked so it doesn't get expressed, or stimulated in a way that it gets overexpressed. I'll be interested in all of your thoughts on it. I think this is a pretty early field, although it's been studied for decades, in trying to understand how it impacts people. But I'll give you a couple of thoughts about it. I think it may turn out to be extraordinarily important because, as Dr. Bob just said, a lot of this depends on your environment, and there are things that you can modulate. If you know, right now we don't really know what they are, but there are a few classic examples of epigenetics. My favorite one is when a caterpillar turns into a butterfly, and the gene sequence is unchanged, but something, and the scientists who study this probably know, but some combination of light and heat and change in environment results in different genes being expressed that can actually make a caterpillar become a butterfly. I mean, imagine that. And so there are a number of diseases, a number of examples of diseases where epigenetics has clearly played a role. Well, one was in World War II, in people in Denmark who were starved. The Nazis prevented food from getting to them, and a number of them were pregnant, and were just totally undernourished. And the observation was, which was an epigenetic observation, I think it's better understood now. The observation was that their children just had a terrible problem with obesity, and the rationale for that was that the mother, her body, because she was being starved, had turned on all these genes that said, eat anything you can get your hands on. I feel like I have that gene, actually. But it's long past World War II.
I'm with you on that. So I have a question for you, Dr. Marschall. Do you think that epigenetics will play a factor in maybe reversing some of these strongly genetic conditions? And what are your thoughts on that?
I think absolutely so. So, one thing that I love about WellWaveNOW is the focus on doing things that are going to make you well, or improve your wellness, not so much treating, your end-stage disease. And there are some studies that are being done. Actually, a really interesting one has to do with aging, and the concept that epigenetics may be a factor in aging. And I think what people don't know is, and I think there's some pretty good data for this, certainly in mice, and a Nobel Prize came out of this, a Japanese investigator who was studying epigenetic changes in mice and found 4 factors that caused mice to age prematurely, or when prevented, caused mice to live for a long time. Now, humans aren't mice, and it may be more complicated, but and that person was directly overexpressing, making the body of these mice have many more of these epigenetic factors that were causing aging. But if we could figure out some of that, and it almost certainly has to do with environment. I mean, the worst thing I can think of from a personal standpoint is that it involves no more meat, exercising every day, controlling my body weight, never having any alcohol. So do we have to do it that way? So we got to find some better solutions than that in terms of our behavioral changes. But I'm a true believer in that, and I think it's early on, and I can't wait to hear what people discover, because the rate of discovery with AI, I know I'm going on and on about this, but the rate of discovery now is so fast compared to 10 years ago. I think we'll learn a lot about this in the next 5 years.
So Dr. Marschall, what role do practitioners, doctors like yourself, have in recognizing when a patient should have, recommend having genetic?
I think there's several. One is to take a very careful family history and find out, did you have relatives who had any of a number of things? But one of the easy ones in cardiology, not easy, is say, did you have any relatives who at a young age died suddenly? And if they do, then they probably had a cardiac, a lethal cardiac arrhythmia. And so I went through 4 or 5 things that could have caused that. And then to think about testing in that person. And genetic testing even, and as Dr. Bob said, I completely agree. There are both false positives and false negatives. But even with that, I think it is much more accurate than the other tests that we have, like an electrocardiogram and an echocardiogram, speaking of the heart. And in fact, they're speaking about epigenetics. There are people in the same family who have the same mutation. And in one person, it can be really problematic. In another person, it may not be. And I believe, and you guys are more an expert in this area than I am, that when you think about lifestyle approaches, that we probably stumbled into, and you probably have more deliberately than I've stumbled into, come across things that we could be doing with our lifestyle that do, in fact, have a positive impact in terms of genetically related diseases, whether it's single gene or multi-gene like atherosclerosis.
Yep, I think some of the things that we've looked at and come across now, it even can be the exercise, the type of exercise for certain conditions can do things. Certainly the diet can, and certainly how one handles stress, and as well as certain toxins in the environment too. So all those things kind of, as we've talked around experts and learned ourselves for ourselves, that those things factored in. Couple things when I ask along these lines we went into is, well, one, I keep getting back to, I'm really applaud that the University of Michigan can get some results back, in I think it's in 24 hours or $400. Because I was hearing on some of these neurological tests, genetic tests, and the cardiology ones, that sometimes physicians are waiting 8 to 12 weeks to get results back. Is that a case enough that you've heard in other environments that aren't using the same type of lab that you are, Dr. Marschall?
Well, what I'm talking about is actually quite recent. So I think what you just said, Tim, has been the standard, 2 or 3 months to get a test result back. And there's some big companies that do this kind of sequencing, particularly in the cancer field.
Yeah.
But even the best of them, it was taken, a month or certainly weeks. This NGS, as you correctly called it, next generation sequencing, I think is changing all of that. And so I believe that will sweep across medicine in the next year or two, that people will find out that physicians and health systems and will find out, gee, I can get this genetic sequencing quickly. Now, there's another important component, which I'm sorry to interrupt you, which is the importance of genetic counselors in helping people understand what their genetic liabilities are, for lack of a better term.
Great. So what, in taking that difference from the standard, used to be a couple of months to get it back to 24 hours, what does that enable for your practitioners? How's that change the way they practice and interact, and then what does it change for I know this is kind of sweeping because we already said, like, very well, for Huntington's it might manifest itself later is not anything can be done for, but there are cases when it might change the care plan. So what does that time difference kind of do for your practitioners, Marcia?
Well, here at Michigan Medicine, it has been most rapidly taken up by oncologists. And there's a great reason for that, which is genetic abnormalities can present with a similar, what we call a phenotype. It looks the same, but the medications that are most effective may be different depending on where that genetic abnormality is. There's some, I don't want to go too far into jargon, but there's a gene that drives a lot of cancers called KRAS, KRAS, and but it presents in lots of different mutations with KRAS, and different medications can be more or less effective. And so a very related field is that I think is really exploding already is pharmacogenomics. So trying to think about what exactly would be the best medication for a person with this genetic abnormality, and what is a waste of time. That's just not going to, why try it? Generally, oncology, I'm sorry about Dr. Bob, go ahead.
No, I was just going to say Breck is driving that topic for our group because he's really into that. I think it's fantastic myself. So I just wanted to jump in there and say that.
Yeah, and you too, Dr. Bob, because you think about, you've seen all those drug studies, right? You've seen the results, and you saw that a certain percentage of those tested can't even metabolize the medication, and that's just one medication being tested on a patient, not considering the 5 or 6 other medications they may be taking and how that's going to alter the way that medication reacts.
Absolutely, it's quite a maze of possibilities.
Dr. Bob, I want to ask you a question because it's not an area that I have great expertise in, but when I think about the complexity, not just of the genetic abnormality, but medication interactions, um, where do you think we are on the spectrum of understanding that versus needing more information to know how to
We're probably nowhere. I mean, because when clinical trials are done, as they test one drug and they get it to, and we generally are testing a pretty not healthy population because our whole United States population is unhealthy. So you got one drug going into a relatively unhealthy population, and then we get the results from that, and it looks like it's promising to help some of those unhealthy people. But we don't test any drugs on healthy people because there's no need to. You know what I'm saying? If you
right?
took a bunch of unhealthy, like me, I don't take any pharmaceuticals. I haven't most of my life, and except under emergency situations. And why would I participate? What kind of clinical study would I be helpful for when I don't take anything? So,
Right.
so I think we don't. And then out in the world, we combine drug A with drug B, and all of a sudden our evidence base is gone. Then we throw in drug C, our evidence base is still gone. And D and E, we have older folks who are taking, 5 to how many? Breck, more than I do about this, or 10, 5 to 20 medications. I mean, it's wild. So I don't think we know much of it at all about that. So that's why we're into wellness, is because what can we do to help these people reduce their medication load? And how can we teach doctors how to, and the pharmacists are going to be really helpful in this regard. How can we teach doctors to pay attention to, what drugs are being taken? I mean, as you know, in cardiology, when you specialize in something, we don't really pay that much attention to the other disciplines, like what else do they have on board? And and our doctors are busy, and it takes a lot to coordinate all this stuff. That's where the pharmacists, and Breck, way more about this than I do, but I think the pharmacists will play a strong role in this. So in terms of drug interactions, I really don't think we know some. Well, clearly we know some stuff, but there's so much we don't know. So I'll stop there.
Yeah, makes sense. Well, just speaking of the role of pharmacists, when I started in healthcare, we never saw a pharmacist on the inpatient service if we were rounding in the coronary care unit or something like that. Now the pharmacist is an integral part of our team. So
Yeah.
helpful.
And rightfully so, because they know more about the drugs than most doctors, for sure. I
Yeah,
mean,
yeah,
doctors get not a lot of training in medical school. When I went to graduate school, I took all the medical school courses, and we got 6 months of pharmacology, and that was it. And for the medical students, and then in my PhD in pharmacology, I did 4 years of drugs and drug mechanisms and things like that.
one of the use cases that I think about is having to do with cholesterol lowering with statins or other drugs. So these statin drugs were tested in these huge populations of people, 20,000, 40,000 people, and they showed a reduction in heart attack and need for bypass surgery, et cetera. But when they have more recently, when investigators have gone back and looked at them, what they found is that effect was huge for some people and not non-existent for others. So we're treating all these people with statins, which are not
Yeah.
free of side effects, and a big bunch of them weren't getting any benefit.
I love you, Dr. Marschall. It's so beautiful. Because we need to be looking at things like that. And that whole statin story is just complicated. And
It is.
I'm not going to say any more about that.
But I can tell all of our listeners, please go back, a couple of episodes and listen to the whole podcast we did specifically on statins. So it's pretty interesting to me that, it's the most popular, most prescribed medication in the entire country, right? And there's still probably 50% or even up to 70% of the patients taking a statin that aren't getting the intended benefit from it. So,
right.
Yeah.
Interesting.
So
I would say, are they getting the intended benefit today from our genetic testing, Dr. Marschall? That's the.
Well, I think, let me put it this way. I think it's step one out of 3 or 4 or 5 steps.
Right.
So
Yeah.
having the gene sequence is great, but it doesn't address ways that epigenetics, as Dr. Bob mentioned, or Tim did, may be playing a role. And it certainly doesn't, we don't know enough to know. I maybe in some period of time, we'll know what genes and drug interactions, what the relationship is, but we just don't know it right now.
So one thing about sorry, Tim, I'm just going to jump in here real quick. I think that the genetic testing provides a real opportunity to give people a window into the potential of what they need to be watching out for. And then they can make all kinds of lifestyle changes if they're able to get into the epigenetic world where, your environment can maybe change the way your genes are expressing. And So I think it's important in that regard because people are, otherwise we're living life and we have no idea. It's almost like, you're walking across the street and there's an invisible bus coming and you don't see it and you get run over, it's kind of like that.
Yeah,
So the genetic testing can at least reveal that there's a bus there.
a good analogy.
A question becomes, as you guide practitioners, work practitioners, advise practitioners, how do you advise them, whether it be on the cardiology side or the neurology side, when they do these testings and they find things? How do you advise them to then work with their patients? What's changed? What do you ask them to do with their patients with that equipment? Now you talked about having the counselor in there. That was one thing, but what else do you advise them now to take action on with these patients?
Well, I do advise people, and I do myself, sometimes get genetic testing just because I don't understand what's going on. Yeah. So, for example, I'll give you a couple of examples. We'll see, and I'm a cardiologist, we'll see somebody who has advanced atherosclerosis but doesn't have any risk factor we know of. And so I'm not sure whether we'll actually find anything, but we do have, our hospital does, and most hospitals have an accumulating large database looking at situations like that. And likewise, it's just amazing. I mean, the example that's given commonly has to do with lung cancer and cigarette smoking. There's no question there's a link between cigarette smoking and lung cancer, but some people have smoked 3 packs a day for 50 years and they don't have lung cancer. I mean, what's that all about? So I don't think we should individually feel like we can work that out, but I think collectively we can. And so NIH has a big study. What's it called? I'm blocking on the name of it, where they have enrolled 1 million people of all different ages, demographics, and this was early on. They were sequencing them all, which was fantastic. Now, of course, they can sequence them much more quickly. But the NIH has that. Several of our startups and pharmaceutical companies have those databases. They're more, in that setting, they're more typically focused on a specific disease that they're interested in. But I think as we accumulate those data, we'll really be able to have smart people who are informaticians, people who their field, rather than working things out in a laboratory like Dr. Bob undoubtedly did, they work it out by interrogating databases. And one thing, this doesn't have to do with patient care exactly, but when people ask me who want to have a career in medicine and science, I say, boy, I think that's the future, is being able to be one of those people who can really ask and answer important questions that relate who we are, what we do with ourselves, and diseases or prevention of diseases.
So along those lines, we said that the future of things, couple of things. One, this may be a look back, but what we didn't really talk about, what captured, there's a lot of things you've looked at and you've done in your career and you do today. What about this and genetic testing captured your interest and your desire to focus on it and provide leadership in that area?
Well, I've always kind of been interested in genetics. I don't know why exactly, I just have. And I was a little bit interested because I have one part of my family, they're deceased now, but were ranchers. And so they were always looking at ways to breed cattle that would grow faster, produce more pounds, you sell cattle by the pound. But the other was on my maternal side, I learned that my maternal grandmother had two aunts who died suddenly at the age of 18. And nobody thought, well, what the heck? Who knows? One of them was running for a train. Then years later, I have a first cousin who had sudden cardiac death, but survived. So she died, got resuscitated and survived. And she had been told that she had a heart murmur, but nobody thought anything of it. So it turned out that she had hypertrophic cardiomyopathy. And our family became, this was being studied at Baylor Medical College at the time. And so we were one of many families who all gave blood to Baylor to try to understand. The investigators there, a guy named Christy Ballantyne, was studying what genes are related to hypertrophic cardiomyopathy. So they couldn't really pin it down for our family. For some families, they can pin it down, but we clearly had this family tendency. And my grandmother had hypertrophic cardiomyopathy, and my mother had kind of a variant of it, although they both lived to be 94, so it obviously wasn't the worst form of hypertrophic cardiomyopathy. So it's kind of, and that's why I went into cardiology, to tell the truth. So that kind of
Where were their symptoms? What were their symptoms?
well, my older age, when my mother and my grandmother got older, they had some symptoms of heart failure, which they had not had. My mother had an arrhythmia called atrial fibrillation, which is common, but is more common in hypertrophic cardiomyopathy.
Mhm.
And none of them, but except for my cousin, had a fatal arrhythmia, and she recovered from hers.
Is early heart failure one of the main symptoms of
Yeah, it's a symptom because it's weird because the heart is really muscular, it contracts really well, but it doesn't relax, so it can't fill up with blood and contract again. And so people with that illness, if they over exercise, this is what's happened to a bunch of athletes. At the peak of their exercise, they're just not getting enough blood to be able to pump out because the muscle is so thick it won't relax quickly enough.
Can we touch on AI a little bit and machine
Yeah.
learning and how that's helping doctors interpret the data? So how is that being used there at your hospital?
Well, it's being used. We have a group that is interested in precision health, precision medicine.
Mhm.
So they're the sort of focus of doing this kind of work. Their work is mainly research, but increasingly, electronic medical records are incorporating AI into the data they gather. And the big electronic medical record is Epic, which many of you and our listeners may have heard about. There's one that used to be called Cerner, but it's called Oracle. Oracle is not nearly as prominent in its use, but it has very sophisticated AI and machine learning. And so I think as those technologies really get incorporated into electronic medical records, that's going to be a big boon for clinicians because
Doctor,
it'll tell them what to look for.
maybe we'll have to reach out to them, see if they'll be a sponsor of the show since you gave such a glowing
Yeah,
endorsement.
yeah.
But how much? So along those lines, of different question on that. So you mentioned in my terms, some of these diseases have commonalities in the genes, and so it may express itself one way. Not express itself. It may be one thing, it may be another thing. How do you get clarity on that, if you can, saying if hey, it could be these two or three things, but which one is it? And how do you see the AI playing a role in helping that in the future? Or I'll ask it in a non-leading fashion. How do you get clarity today? And how do you think that the ability to get clarity on that will change over time?
Well, today I think, as I said before, we just don't quite know enough.
Okay.
But except in some areas. So, for example, there are multiple genes, different genes that can cause hypertrophic cardiomyopathy. And even within a single gene, some mutations tend to give the most lethal phenotype, the people that are most likely to have a fatal arrhythmia, while other mutations in the same gene are not very dangerous. And so this is slowly being incorporated. For example, the wisdom about people who were athletes in high school who were found to have hypertrophic cardiomyopathy was they should never do competitive sports again. Now we know that that's not true. And actually, genetic analysis has helped with that. And if they have a certain genetic abnormality, they probably should not do competitive athletics. Others, it's low risk. Some of this was done a little bit by family history, because if they had multiple people in their family who died at a young age, they're obviously in a high risk group. But now we now know much more about genetics and being able to predict who is at highest risk. So I give that as an example. I think there are many examples that are nascent and we're starting to understand them better. So I think that's got great promise. And Breck, as you were talking about electronic medical records, I do think you ought to reach out to Oracle or somebody there and get them hooked because they're doing fascinating stuff.
With all that, so I think you've been realistic, in which we appreciate in the way you've expressed where genetic testing is today and what is known and what's not known. But now with that realism, I'll ask you a little pointed question then.
Sure.
Should practitioners and should patients today be doing the testing, and why?
I think that this is my opinion. There are no guidelines that say this is what ought to happen. I think anyone who's interested in genetic testing should have the availability to have it done. But I think it's really important today. It may be different when we have more AI, more machine learning, but I think it's very important that that be done in a setting where there is the availability of a genetic counselor who can help them understand this. Because frankly, I like to think I know a lot about cardiology, but if it was me or a patient of mine, I'd want them to be able to sit down with a genetic counselor and really go through everything, because let me just put it this way, they're unbiased, and they'll look and say, well, here's what you have. Here's what we know a lot about. We don't know much about this, but you should keep in touch because we will know more about it. So I think it ought to be offered to anybody who wants it, because it's cheap. It's one thing to say, for example, there are these CAT scans that screen for calcium in the coronary artery. Well, you get a coronary artery calcium score, a CAC score. And they're getting less expensive, but even that, which gives you only a single targeted answer, that's a few $100s in the best of circumstances.
And could save your life.
Yeah, absolutely.
Yeah. So we see how well, AI is going to speed up the data analytics. Is it going to also help, you think, to prevent misdiagnosis and those risk factors as well?
Yeah, I look at it, this may seem overly optimistic, but I look at it like it's a lab test. So, if somebody comes in and we were talking about brain fog, if they have a terrible brain fog, where they're just not able to think clearly, the first thing you'd want to do is get their electrolytes, get their sodium, potassium, et cetera, see if there's an abnormality there, or if their glucose is 800, any of those things could cause somebody to have trouble with their thought process. And we're not there. We don't know that much about all the information we get from genetic testing today. But I think with AI, it'll soon be the case that with certain presentations of patients, they ought to get a whole genome sequencing and analysis. I don't think we don't have the analytics haven't caught up to it yet, but I think they will.
Well, then two other quick questions for you. I appreciate your time here. It came to mind, the CRISPR technology, where you're supposed to be able to snip out the genes and how much hope are you putting in that for future developments, Dr. Marschall?
Well, right now, so CRISPR is being used. It's approved actually for a couple of diagnoses, but it's being used in very specific single gene diseases. And it can either take out a gene or it can put in a gene. The technology for using CRISPR has gotten much better, because initially you couldn't control, I don't do this technology, but you couldn't control where in the genome your new gene sat. So it might sit somewhere that turned out to cause all kinds of problems. Now it can be targeted to exactly where it needs to be. And to give you an example, there are a couple of different kind of hereditary and genetically based hearing problems, total hearing loss. And it's now possible, once you know that gene, once the physician, the ENT guy or whoever knows that gene is what's causing the hearing loss, it can be fixed with CRISPR technology. And so there's some small series out there, 10, 15 people, who have had, and sometimes it's with CRISPR, sometimes it's with RNA technology, but it's the same general principle of correcting an abnormal genetic sequence. So I think for what I called initially monogenic diseases, where a single gene is causing the problem, I think it has great potential. That is not the majority of medical problems we have in America. If you look around at obesity and type 2 diabetes, those are polygenic. So we don't have an answer for those with CRISPR or RNA technology, but there are certainly devastating diseases that if we knew about them.
We have an answer.
Okay, I'm listening.
Yeah, get off the couch, right? Stop eating Twinkies. It's lifestyle changes, obviously, but we do get the cards that were dealt us in genetics, but it doesn't always need to be our destiny, is what you're saying.
Right.
We have
Absolutely
to make some changes.
You're absolutely right, Breck. When I look at the fact I see in the advertisements, and when you talk about the weight loss drugs that are helping people lose 15 to 20% of their weight in a year, I look at that and said, now, Breck's heard me say this a million times, and I go up and down, but this might be the first time for you, Dr. Marschall. Okay. I was a 126-pound collegiate wrestler, got up to over 250 pounds at one point in time. Okay. And so I've come down, I go back up times. But I can lose that same amount of weight in that amount of time or faster if I simply go to a low glycemic index or low glycemic low diet for myself. And in 3 to 5 days, I can put myself into what's it called dietary ketosis. And I just that I don't need to take that. So people can get that same amount and more with those relatively simple changes, actually.
Yeah, I do think those drugs have a role because they are very powerful. But as you were alluding to, sorry, somebody's knocking on my door. There's also this incredible literature about low caloric intake, producing health, producing longevity. And I have to reluctantly admit that I have trouble, and so I have trouble throwing weight. I can lose some weight, and then I pass my favorite donut store, and all of a sudden I'm off. And it used to be 20 years ago, I was up and down, up and down. Now at least it's a smaller up and down. But some people, it sounds like you're able to do this well. Some people that works well for them. And talking about epigenetics, so getting back to epigenetics, I'd love to know how much of that is an epigenetic phenomenon, that they have a tendency that if they make lifestyle adjustments, it produces these epigenetic factors that regulate their genes. And maybe it's not, they've inherited those epigenetic tendencies. Maybe that's part of what it makes it more possible for them to do that, because
and for me, I'm not perfect. I go up and down. I fall off. Sometimes I'll fall off for months. And I'm the type of person, I'm gene expression portion, that for me, I literally can put on 10 pounds in a weekend. And it's not a problem for me. So I go.
Not a problem.
For me to put that weight on, it comes off a lot slower at times, but appreciate that. Breck, you have any questions for Dr. Marschall here?
No, I just want to thank him for coming on the show. It's been absolutely fantastic conversation, and I'm so interested in what the future of genetics and precision medicine, what that's going to look like in the future with how quickly things are moving today. So absolutely loved having you on. Look forward to having you on again. I understand you have a book that's going to be coming out soon, so we want to have you back and we'll talk about your book.
That would be awesome. This has been a blast. And it's the most fun I've had. Well, it's only Tuesday, but it's more fun than I will have had by the end of the week. I had this hour with you, so I really appreciate that. The book that's going to come out is going to come out in May. It's a book with Forbes Books, and it's about my opinion of where we stand today in healthcare and where we can look to the future. Some of it's technology, but an awful lot of it is focusing on things that you both focus on, and preventing ourselves and everyone from getting into this cycle of illness that is pervasive in the United States.
Yeah, as well. To our listeners, I've had a sneak peek. It is going to be wonderful read, and look forward to that coming out so the rest of our audience can enjoy it as well. So thanks again, Dr. Marschall. So great to have you on. And for next, we've got Jeff Pearson, our Hero Series stories coming up for next week.
Oh, yeah, I'm tuning in.
All right. So what we do, Dr. Marschall, on that is we take people that have gone through, I've had just what in many cases devastating things happen to them. How have they not given up? How have they found the solutions that allow them to have optimal health and in many cases thrive? And with Jeff, he's one that had the hydroencephaly brain, so he's had the shunt in his brain, and has had to have that replaced multiple times, and those replacements have caused issues with him. And he's really found ways to address those issues, overcome them, and thrive, and be very, very healthy and have a very rewarding life with it.
Yeah,
sounds like a great session.
Will be great. But hey, thank you again, Dr. Marschall. So wonderful to have you on the show, and look forward to having you back again to talk about your book when it's released.
Wonderful.
All right.
Keep doing what you're doing.
Hey, everyone. Remember, wellness, it's in you.